Well, now that we finished on time, you folks will have to suffer us through some more questions with regard to demographics and how you treat your patient. May I have the first slide, please? The ARS, please. Oh, Lord. What country do you practice in? China, Taiwan, Korea, India, Thailand, or other? Again, please. Maestro. All right, let's see what we have. It looks like things haven't changed very much since the last time. All right, your gender is, folks, I hope you haven't undergone any sort of operation in the past evening. It's male versus female. Again, a preponderance of males. Folks, I just work here. I had nothing to do with asking the same question over again. Your age is 20 to 40, 40 to 60, or more than 60. Maestro. Well, it looks like the old folks have lit out already. Treatment of choice for newly diagnosed CML in accelerated phase. A, imatinib. B, dasatinib. 3, nilotinib. D, chemotherapy. And E, allogeneic stem cell transplant. This is an accelerated phase. Dasatinib. I see that you folks have been listening to some of the lectures. I'm not sure that I agree with that, but nevertheless. Next question. Treatment of choice for patients with minor cytogenetic remission after 18 months of imatinib-based therapy. A, nilotinib, B, dasatinib, and C, allogeneic transplant. Well, we have a wide difference of opinion here. Now, that'll be interesting to... I'm not so sure what I would do yet. I don't think I'm going to comment on that one. Next slide, please. Treatment of choice for patients with relapsed CML on imatinib. A, nilotinib, B, dasatinib, and C, allogeneic transplant. Good Lord. I think the drug companies would be very interested in this answer. I'm not sure I'd go to an allo right off the bat. Next slide, please. Treatment of choice for relapsed CML and now in second chronic phase. A, dasatinib, B, nilotinib, and C, allogeneic transplant. I think it depends on what you got after the first relapse. Answers, please. And I would probably be inclined to agree with that. Next slide, please. Do you perform molecular monitoring for CML? A, yes, and B, no. Good. You folks are doing all right. It's been a great session. I don't think you could really practice modern medicine without doing molecular monitoring for CML. Next slide, please. At 18 months of imatinib-based therapy, patients entering a clinical, a complete cytogenetic response but no molecular remission, what is your next step? A, continue imatinib, B, dasatinib, C, nilotinib, D, allogeneic transplant, and E, I don't perform molecular monitoring. Your answer, please. Well, we have a difference of opinion between imatinib and dasatinib. It's a long time to get into a complete cytogenetic response, folks. Next slide, please. Is that it? Mercifully? Great. All right. So let's go into our next session, which is on non-Hodgkin's lymphoma, which will be chaired by Dr. Issa Grissel, who was a gracious host to us in in Thailand, and he comes to us. He's professor and chief of the stem cell transplant program in Mahidol University in Bangkok, Thailand. And of course, Dr. Shpal, who needs no introduction. They will chair non-Hodgkin's lymphoma.
Well, I think we'll begin with our first speaker, who is going to talk about breakthrough in therapy for aggressive lymphoma, mantle cell, and large cell lymphoma by Michael Wang from the MD Anderson. Dr. C.
Wow, this is not my water.
No, don't touch that.
Need some, do another tree. It's my pleasure to come back to this conference from last year, and so Hong Kong is still as significant and magnificent as it should be. And I would like to thank the organizers of this conference to involve me in this conference and in all the APCON-related activities. I'd like to thank Dr. Chaplin, Dr. Samuel Palmer, Dr. Coleman, Dr. Huang, and Dr. Xiaojun Huang, Dr. James Chen, and all the friends that we just having a great time. There's many types of lymphomas and malignancies. There's T cell, then NK cell, there's B cell, and there's T cell. We all know that B cell lymphoma is the most common one. And the B cell lymphomas, so many subtypes, respond to therapies differently. They have a differential significance so far, and it is I work on mantle cell lymphoma and multiple myeloma. And mantle cell lymphoma, I think, if you put all the subtypes of lymphoma and you put their cure rate, their response rate and duration response, the efficacy, clinical outcome together, and mantle cell lymphoma by far is the leading horse. Followed by, I think, with all my due respect, followed by CLL, follicular lymphoma, and Waldenström microglobin large cell lymphoma is last in the race horse. Why? Because it's more refractory and more difficult to treat. So mantle cell lymphoma is a young disease. It was around 1992, the term was coined. Therefore, it's a young disease, but a significant progress has been made. And mantle cell lymphoma in the U.S. is rising because of early diagnosis in the aging population and the global warming and all the changes. Mantle cell lymphoma, we all know, is characterized by the T1114 translocation. It is my belief if we study mantle cell lymphoma, Waldenström's, and CLL, we find the best drugs. If we then combine these drugs together, we would make significant better outcomes in large cell lymphoma. I will show some examples of some single agent that it works over 50–70% response rate in mantle cell lymphoma, 70% in CLL, 70% in the Waldenström's. But when it goes to large cell lymphoma, it's around 20–30%. It's not enough. So if we find many of those agents, we combine them in the clinical trial based on science, preclinical sciences, we shall be able to make a difference in large cell lymphoma. So as we know, either large cell lymphoma or mantle cell lymphoma or B cell lymphoma, they are treated by chemotherapy, radiation, immunotherapy, radioimmunotherapy such as Zevalin, Bexar, stem cell transplantation, of course, and proteasome inhibition. Bortezomib, carfilzomib is approved for multiple myeloma, and we at MD Anderson, we have done a lot of laboratory work with carfilzomib in non-Hodgkin lymphoma, especially in large cell lymphoma and mantle cell lymphoma, and we have already designed clinical trials that is moving on at MD Anderson. And so this is about a 10-year follow-up at MD Anderson up to Harper-CVAD, as we all know that everybody have ever used, at least heard of Harper-CVAD. I know Dr. Niu Ting from Sichuan, who studied with Dr. Chapot, went back home and took the recipe of Harper-CVAD, and he later on reported the good results with the Harper-CVAD. So his hospital is big enough and good, modern, and very clinicians are skilled, very excellent, showed excellence, and was able to use Harper-CVAD. significantly, safely. Carbacevad is A part carbacevad, rituximab, B part benzotrexate, Ara-C, and rituximab alternating for 6 to 8 cycles. This clinical trial that we conducted, published in JCO, we had a 10-year follow-up. The 10-year follow-up rate, as you can see, even after about 10 years, the median, only around 50% of people around the overall survival was reached in the elderly. In the younger patient after 10 years, the median the median was still not reached. So carbacevad could result into long-term remissions, especially in young people. Time to failure is not plateaued, therefore, since we still see once in a while a patient will fall off, therefore mantle cell lymphoma remains incurable even with carbacevad. And those are the according to the old prognostic factors, according to MIPI, the younger patient, the lower MIPI patients did better than the higher MIPI. And mantle cell lymphoma is still a very malignant disease. This is a person, this is one of my patients at MD Anderson. He had a terminal mantle cell lymphoma. As you can see by PET-CT scan, his mantle cell lymphoma is in the thyroid, in the lungs, in the muscle, in the bones, in the kidney, in the liver, it's everywhere in the body. You can easily imagine large cell lymphoma could do this as well, almost on a daily basis around the world. Many combination therapies for mantle cell lymphoma are listed. Their response rate is not very satisfactory, usually in the ranging from 30 to 100%, but mainly around 40 to 50%. If you tell a patient you only have 50-50 chance to respond to a combination therapy, that's really not ideal, and the patient have to also suffer the complications as side effects. I have many slides, and I mainly put this here so that you guys could have these slides, but this is a new era for novel therapies. As you can see, the targets that we are designing drugs for are like a star in the sky. There's many targets, and it's, only a few of the targets are listed here. There's just too many to put it on the slides. This is published by Dr. Søren Brisky and Dr. E. Comis this is published in Cancer Medicine. This is modified the slide from the publication. Let's look at the mantle cell lymphoma. Let's focus on mantle cell lymphoma here for a moment. You can see that the mantle cell lymphoma, the best therapy, as shown in green, is Ibrutinib, which all see in the past PCI 32765, is a single oral B-cell receptor pathway inhibitor. And it is single once a day. It takes, as shown in green, the single agent activity in relapsed refractory heavily treated mantle cell lymphoma is 69%. Followed by Cal-101 is another kinase inhibitor, 48%. Followed by cladribine, an old anti-metabolite chemotherapy, 46%. Followed by lenalidomide, 42%. In that publication, but later on, most recently, lenalidomide has been filed for mantle cell lymphoma in the U.S. to the U.S. FDA, and the Dr. Andrew Wang, my colleague, presented that at ASH, and the publication is being submitted, and I think this drug should be approved. It's an oral agent once a day. Is immunomodulation, and our patient need this drug, and the drug has shown efficacy and a good tolerability, and I think the drug shall be approved maybe this year. So we would have a second drug approved this year in addition to bortezomib and the Revlimid, and very likely Ibrutinib also this year. And so next to lenalidomide down the line is tacrolimus, also called CCI-779, is an mTOR inhibitor, is approved for mantle cell lymphoma in Velcade refractory patients in Europe, but not in the US. Rituximab alone, as we all know, have a 37% response for single agent bortezomib, and as shown by the Preclinical study, 33%. And Ibrutinib, as shown by Wang et al., 32% single agent. And unfortunately, the second generation mTOR inhibitor, which is RAD01 everolimus, approved for the renal cancer in the US, was failed to show good response in mantle cell lymphoma, and it was only 12 to 15%. At MD Anderson, we do emphasize on preclinical science. This is Dr. Xiaohong Han, my student, PhD student, from the sister institution, Chinese Academy of Medical Sciences. She published with Dr. Liu Zhang in 2008 a SCID-U model. In this model, we put a human bone chip in the mouse, and we injected patient primary cells into the do we have a pointer? We injected primary fresh tumor cells into the microsection of the bone marrow, bone and vein. They will grow, and as you can see, with the time, the human beta-2 rises as we together parallel when the tumor volume increase. As you can see, control the bone itself. But if we injected 0.5 million fresh patient cells, we find the tumor grew out of the bone. As you can see, this is the expansile part of the tumor. This is the bone, and the HE sections morphology looks like mantle cell lymphoma, CD20 positive. And also, this positivity is also shown positive in lymph node, positive in spleen, positive in the lymph nodes, positive in the spleen. This should be the bone marrow, but negative in the liver, and positive in the GI tract. This mimics the natural history of human mantle cell lymphoma. This, in addition to cyclin 20, in addition to CD20 positivity, cyclin D1 is also positive. And then we injected the anti-lymphoma drug, the beta-2 would decrease. This is really a very good model for mantle cell lymphoma. Mantle cell lymphoma, these days, the therapies across the board translate, dialogue each other. What's used in mantle cell lymphoma could be used in multiple myeloma. Mantle cell lymphoma learns from multiple myeloma also will learn each other. Also, of course, from each other, of course, the large cell lymphoma as well. This is switching gear to Revlimid, lenalidomide plus rituximab in mantle cell lymphoma. We started the preclinical. We showed that this combination can decrease the tumor volume and prolong the mice survival. And then we designed a clinical trial. We presented in Lugano, and we published that in Lancet Oncology, oral lenalidomide plus 4 doses of rituximab in mantle cell lymphoma relapse setting. This is a phase 1 and 2 clinical trial. Phase 1 trial is 3+3. Phase 2 trial is included 46 patients at MD Anderson. It took me 7 years, and took all of colleagues 7 years, including me. And the side effect is very tolerable, as shown that the bone marrow suppression is not severe. The response rate with a single agent lenalidomide, with 4 doses of rituximab, with most of the single agent and the 2 drugs combination, but with only 4 doses of rituximab, was 47%. This really, I think, is a very good data. This is almost as good as combination of chemotherapy, yet this was a pill. Time to response was fast with only 2 cycles, and in addition to, there's about 21% of stable disease. Essentially, on this, only 21% of the patient did not respond to therapy with progression of disease. Median duration of response was 18.9 months. The failure-free survival was very reasonable. For Velcade, it was 6 months. For this combination was 13 months for the whole group. In conclusion, this is a good combination, lenalidomide plus rituximab. It is good for mantle cell lymphoma. That's published. And we also did the same study with another 40 patients in large cell lymphoma. We have submitted, finished the trial, presented the trial at international meetings, and for large cell lymphoma, the responses are less, but the activity is very good. It's not here for the large cell. We didn't have time to show it here. For large cell lymphoma, the follicular group responded better in 50%. The transformed lymphoma had around 30%, and refractory large cell lymphoma around 25%. This is a mantle cell lymphoma patients with mediastinal mass before the trial and also abdominal mass. After 2 cycles, it shrunk, and after more than 2 cycles, it disappeared. Carfilzomib is a multiple myeloma drug, was approved on July 20th of 2012 for multiple myeloma relapsed after Velcade. But carfilzomib, we learned from the myeloma experience. We tested the carfilzomib in mantle cell lymphoma. We found carfilzomib is able to cause apoptosis, inhibit growth, decrease the tumor volume, and improve the survival of the mice in our tumor model. We've shown many mechanisms, and we have designed, building on our success, we have designed, and based on all the preclinical data, the myeloma clinical data, and preclinical data in mantle cell lymphoma, we designed the CR2 protocol. The CR2 protocol is a very exciting protocol. The CR2, C means carfilzomib, R means R Rituxan, another R, R2 Revlimid. In mantle cell lymphoma, this has already passed the MD Anderson IRB, and we are in the process of revising this CR2 protocol. In addition to mantle cell lymphoma, we were going to include large cell lymphoma, follicular lymphoma, CLL, Waldenström, macroglobulinemia, and it is really a paradise time for clinical trials in lymphoma. In phase 1, we determined we would like to increase. This is all the background slides I already told you. This is the possible. So that this clinical trial is going to be going to enroll patients very soon. So let's switch gears to yet another possible mechanism. As we all know that Ibrutinib BTK inhibitor is Bruton's tyrosine kinase, as we can see, is a very critical component of the critical pathway on the B cell malignancies. And we think carfilzomib and Ibrutinib could synergize together in terms of mantle cell lymphoma, as well as CLL, Waldenström's, and all other possible lymphomas. And we can see that the growth of mantle cell lymphoma cells inhibited by Ibrutinib alone, with the exceptions of normal B cells as a control, and the DB-SP53 did not respond as good, but the rest of the culture cells, mantle cell lymphoma, responded to Ibrutinib in vitro. Based on all the preclinical science, not only done at MD Anderson, but all done with many the science colleagues from many years of therapy, and the many years of scientific research, and the single agent Ibrutinib was studied in an international clinical trial, and that consists of 18 centers. It was my pleasure to represent my colleagues of 18 institutions and presented at this ASH last year at Atlanta, 2012. In this, we show that the single agent Ibrutinib, taken once daily, each cycle 28 days, the oral single agent did not cause too much toxicity at all, and the neutropenia and bone marrow suppression was not very common at all, and the response rate was 69%, and despite either the response rate is 65 to 79%, either Velcade naive or Velcade treated. This is the patient who has a tumor on the right neck. Is my patient with mantle cell lymphoma, and as you can see, the tumor on the right neck is biopsy proven to be mantle cell lymphoma. After 8 days, single agent oral therapy shrunk. After 15 days, no longer palpable. As you can see, the lymphocyte at the baseline after 8 days climbed up, and it is even higher on day 15. We described this at our ASH presentation to be compartmental shift syndrome. The tumor cells shifted from the tumor department into the peripheral blood. This is a patient with a bulky mediastinal mass. As you can see, that before the clinical trial, the patient has a mass that measures 8.3 centimeters in the longest diameter, and it compressed the trachea, caused the patient to be short of breath and chest pain. And after, this is also the another lymph node below another lymph node. So after 2 cycles therapy, the tumor has shrunk. Please, before 2 cycles, after 2 cycles, the patient was able to take a deep breath. MD Anderson, among 18 clinical centers around the world, MD Anderson contributed to 30 patients of the 115 patient population. These are all the MD Anderson study subjects, patients. The green means green light, see complete remission. Yellow means yellow light, PR, partial remission. And the red means red light, progressive disease. Stable disease is shown in blank. As you can see that some patients started with a stable disease, and partial response, then become complete response. So there's a gradual improvement from stable disease, a better partial response, even the best complete response. We call this gradual response a phenomena, another phenomena of incremental response. Phenomena, let's say this 85-year-old lady living on Buffalo Street Speedway in the West University in Houston. He has a bulky tumor mass below the year ring before the study. 7 days, the tumor is almost gone. So this is another good example. And how am I doing with time, Dr. Chappell?
5 more minutes.
4 minutes?
Yeah.
Okay. So bortezomib is synergistic with the rituximab. This is another clinical trial, and we would like to host the conference sometimes in Shanghai to present, to introduce to my homeland and China, the colleagues and the patients, that the new therapies that we have, the data we have obtained. I'd like to thank everybody. My Dr. Larry Kwok is the chairman of lymphoma, and I have a joint appointment in the stem cell transplant department. Dr. Richard Chaplin, who's sitting in the audience, organizer of this conference, is the chairman of that department. I work very closely with our colleagues in the stem cell transplant. We would like to show some agents in the post-transplant setting what the new agent could do. This is another clinical trial with Yttrium. Yttrium, the Zevalin with the single agent mantle cell lymphoma, the response rate is not great, but in some of the patients, the duration of response is very long. So I like to open the floor up for questions. I do mantle lymphoma and myeloma, and it's just like the two kites in my heart. Thank you.
Do we have any questions?
So thank you very much, Michael.
We have one question I see there.
No, can't let you get off the stage without giving you one question. The problem with the Zevalin in mantle cell is that the mantle cell is so very often involved in the bone marrow that it doesn't become as useful an agent as we would like. Do you use your Zevalin after you give them some chemotherapy to clean out the marrow, or do you just try to start from the get-go and give them the Zevalin? Or do you use the same criterion of 20% cells not allowing you to give the Zevalin? 20% of lymph cells?
Yeah, we use the platelet level to be over 100. And we use, Revlimid is very rarely used. So I use it in the elderly who does not have bulky disease, whose marrow is still good, and is not eligible for a clinical trial. I use Zevalin.
The Zevalin, but the problem with mantle cell is that so very often it involves the marrow, and at least our exclusion criterion, if you have more than 20% lymphoma cells in the bone marrow, we can't give it. So we found that the Zevalin wasn't very useful since so many of these patients.
What I do is I use cyclophosphamide with some other Revlimid to clear the marrow.
Right.
And then when they are good, I put Zevalin. That's how Dr. Coleman, thank you for the question.
Thank you very much, Michael.